So this will be the fourth paper, which is a modified four flanged intrascleral technique of IOL fixation. Please go ahead.
Good morning everyone. Today I'll be presenting on modified four flanged intrascleral technique of IOL fixation and our 18-month clinical outcomes. It's not moving. Optical rehabilitation in patients with aphakia presents a unique surgical challenge. The choice of IOL implantation in aphakia in the presence of little or no capsular support includes AC-IOL, iris fixated IOL and scleral fixated IOL. Each of these techniques has its own merits and demerits. AC-IOL has the potential for increased damage to the corneal endothelium and angle structures, whereas iris fixated IOL has increased chances of pigment release and inflammation. Whereas scleral fixated IOL has the advantage of more physiological position near the nodal point of the eye and greater distance from the cornea. Now SF-IOLs are broadly classified as either sutured or sutureless. When we come to the sutured SF-IOL, which was practiced more before, suture erosion and breakage was very high. Because of that, the lens dislocation, lens tilt and other complications were also seen. Then the concept of glued IOLs was introduced by Dr. Amar Agarwal sir, in which the biological glue, that is a quick-acting surgical fibrin sealant from human blood plasma, is used. With the glued IOLs, the complications were scleral flap issues, haptic extrusion, and the haptic breakage. And the recently developed Yamane technique, it is generally technically challenging, and the IOL decentration and tilt is also more with this technique. Dr. Sergio Canabrava described the four flanged technique, which is the intrascleral intraocular lens fixation technique with no flaps, no knots, and no glue. In the original four flange technique, the 5O proline suture is fed into the lumen of the hypodermic needle within the anterior chamber and exteriorized through a sclerotomy 2 mm from the limbus on either sides. Further description of the technique I'll give in the further part of the paper. Now, my purpose of this study is to report our 18-month clinical experience with the modified four-flanged intrascleral IOL technique. It is a retrospective study where we considered 52 eyes of 52 patients with a mean follow-up of 18 months. All surgeries were performed by 2 experienced surgeons. The indications for scleral fixated IOLs were mostly intrazonular dialysis, dislocated IOLs, subluxated IOLs, intraop PCR, and trauma. Now this is the modified four flange technique. In this technique, the double needles are pre-prepared by feeding a 5 cm long strip of 6O proline suture into the lumen of a 27 gauge needle. Under direct or microscopic visualization, the needle is then introduced into the sclera 1.75 mm from the limbus. The suture is advanced within the shaft of the needle. Once the suture is visible in the anterior chamber, it is grasped with a microforceps and it is exteriorized. Same is repeated on the other side, 180 degrees apart. Now the suture ends are passed to the eyelets of a PMMA IOL and it is cauterized to create flanges, following which IOL is positioned behind the pupil. Outer sutures are pulled anteriorly and cauterized to create 2 external flanges, which are then buried under the conjunctiva. We believe that this modification may be useful by reducing the maneuvering inside the chamber, as docking of the suture is already done performed outside the eye. Now coming to the results. When compared with the 15 days and the 18 months CDVA, sphere, cylinder and the spherical equivalent, it is not clinically significant, showing that the procedure is stable from the initial and the stability is maintained throughout. And the IOP, mean IOP on day 1 was a bit on the lower side, around 12, and on the 15 days and 18 months it was normal. And these are the clinical pictures showing the stability of the IOL, where we can see the flanges also well centered 180 degrees apart. And this is the UBM post-op 6 months picture, which is showing the well centered IOL. Now coming to the safety profile, the intraoperative complications, there was one haptic slippage which we have seen and one intraop IOL tilt, one haptic breakage. The slippage was due to the inadequate size of the flanges. Tilt was due to the loose flanging. Now coming to the postoperative complications, there was flange exposure, IOL tilt and hypotony. This four-flanged intrascleral technique was better, but then our novel technique simplifies, improves and quickens the single-piece non-foldable IOL intrascleral fixation technique. It also has a lower cost and easy learning curve because it is based on existing scleral suture fixation techniques. Our experience spanning the intraoperative and 18 months postoperative course suggests that this technique of SFIOL fixation is safe, relatively easy to perform, useful in hazy corneas and has a short learning curve.